I am doing my peer checkoff for the vent setup, um, and so the notification would come in that somebody's coming in that's going to need to be on a ventilator. So I would go ahead and get my supplies in the ventilator. I'd get my circuit, my suction catheter, and the T-piece, and then at our facility, I'll just show you this. Oh, we have it set up and ready to go all the time. So here's my circuit. As you can see, here's my inspiratory and expiratory filters. I have my oxygen and air hooked up, if you can see that. And then I have, it's plugged into the red outlet that is connected to the generator should we have a power failure. So basically what I would do, this is set up. I'll go ahead and get my gloves on here. Put this together. The circuit's on, the filters are on, the circuit's on. The HME is here. Then for my nebulizer in line, and then here's for my suction catheter. You can see all that. So basically the physician would verbally give orders typically as to what settings he wants. I would also check a chart, but oftentimes they might have to just enter that later, or I may have to enter that order and then have the physician sign off on that. So as I said, we've got the vent plugged into air and O2, and we're in the red plug-ins. Turn the vent on in back. Turn the vent on. I would go ahead and enter the settings and the modes that I got from the doctor. Once everything's ready to go, when I'm ready to connect it to the patient, it needs to be running, delivering breaths, not in standby. So when it's ready to connect, it's giving breaths. What would happen is the EMT or whoever maybe that is giving them breaths by the ambu bag, they would go ahead and remove that, and I would go ahead and connect to the ET tube. Also, we're going to want to make sure, if you can see here, that the hose is coming straight off the patient, not pulling one direction or another, and that the hoses are not raised up, that they're not condensation or nothing can, if it's up here, it could go back to the patient. So we want those hanging down so that doesn't happen, so that anything can just drain away from the patient. Then I'm going to assess the patient. I want to know their breath sounds and their vitals, their heart rate, respiratory rate, blood pressure, and SpO2. I'm going to go ahead and check the vent settings, making sure that they are appropriate for the patient. And at this point, you know, if I need to do any fine tuning, then I would do that. I would also continue to assess the patient, and if if they're coming into ER, there's just a lot of things probably going on. So I would help the team, whether it be putting restraints on or just getting them settled, helping them roll the patient if necessary to remove clothes or adjust the bedding or whatever. I'd make sure they were at a 45-degree angle. I would make sure that the suction is set up on the wall, and the patient may need suctioned right away. So, of course, if indicated, we would go ahead and do that as well. I have put the SVNT piece in here just in case. And then once the patient is settled, I would go ahead and assess them again, checking their breath sounds and their vital signs. I would, at this point, check the initial cuff pressure and make sure it is where it needed to be, using the minimal leak technique. At this point, I would do my initial vent check, and I would make sure the settings, obviously I would make sure my settings are where the doctor ordered them, or if we needed to adjust them, make sure that they are where they need to be. The FiO2, the eye time, tidal volume, respiratory rate, PEEP if necessary. If they needed humidity, if we thought that they were going to be on the ventilator for 12 to 24 hours or longer, then we would go ahead and add the humidity. And then if the patient's conscious, we would tell them that we'll be back in 30 minutes to do their ABGs. And at that point, I would just make sure that, again, the bed is at a 45-degree angle, that the call light is there with them, that the rails are up so they don't fall out of bed. I would throw away any garbage or anything that I had, clean up any mess or anything, and then I would, of course, let the nurse know if there was any issues, or make sure if they're unfamiliar. We don't use a vent in this facility very often, and so if they were unsure about the ventilator, maybe go over any questions that they might have. And then at that point, I would document and take my gloves off and wash my hands and just make sure the patient was good.